So welcome everyone to my second video. This time we'll be discussing about the new topic, which is especially will be useful for the students who are doing MD, as well as it is common in cardiac anesthesia as well, because the topic is anesthesia in thoracic surgery. So, so this is a topic which is common to both MD as well as DM cardiac anesthesia. So, starting anesthesia for thoracic surgery. So, why do we need the main crux? It will be divided into multiple sections. This is just the beginning, initial part. So I'll be discussing about the pre-operative management, like pre-operative planning of the patient, which will be included in the PAC which you do for such cases. So first of all, why we need to do the pre-op? What are the main concerns that we need to do the pre-op evaluation? Because these patients, this thoracic surgery patients for pulmonectomy or lobectomy, they have multiple perioperative complications. We'll see them one by one. So the most common respiratory complications, the major respiratory complications are atelectasis, pneumonia, and respiratory failure, which constitutes about 15 to 20% of the respiratory complications. And cardiac and vascular complication are the leading cause of early perioperative morbidity and mortality. So cardiac complications, what you might expect, they are arrhythmias plus ischemia. They occur in around 10 to 15% of the thoracic population. So what are the components we'll be looking for in the assessment of respiratory failure? So initially we have to look out for the detailed history of the patient's quality of life. All patients undergoing the pulmonary resection should have baseline simple spirometry done preoperatively. The respiratory function will be discussing in three headings. First is respiratory mechanics, second is gas exchange, and third is cardiopulmonary interactions, which is the exercise capacity. The basic function. So what is the basic functional important function of the respiration? The basic functional unit of extracellular respiration are to move the oxygen into the alveolar, from alveolar into the blood, and from blood into the tissues. The opposite happens for the CO2 removal, which is from the tissue to the blood, from the blood to the alveoli. So first of all, we'll see the first respiratory function, respiratory mechanics. So in respiratory mechanics, the most valid, the most valid single test for the post-thoracotomy respiratory complication is predicted post-operative FEV1. So this is the parameter we have to measure, predictive post-operative FEV1. So how do we calculate it? So predictive post-operative FEV1 is a percentage for which we should know the pre-operative FEV1 percentage, which we'll be getting it from the spirometry. That will be percentage into 1 minus percentage the functional lung tissue which will be removed upon 100 to get the percentage. So we'll be discussing that in detail after a while. So patients with predictive post-operative FEV1 more than 40%, just remember, are at low risk for post-resection respiratory complications. That means the predictive post-operative FEV1 ratio, if it is more than 40, then the patient has very low risk. Risk increases, the major respiratory complications, risk of major respiratory complications increases if the subgroup, if they have a predictive post-operative FEV1 less than 40. So more than 40 is low risk. As the percentage decreases, risk increases. So the high risk is predictive post-operative FEV1 ratio. FEV1 percentage will fall less than 30%. So let's go on to second respiratory function, gas exchange. So gas exchange is nothing but the lung parenchyma function. The mechanical delivery of the air to the distal airways whatever the airways are there, what it does is the mechanical delivery of there to the distal airways. So from the distal airways, subsequent ability of the lungs to exchange O2 and CO2 between the pulmonary vasculature and the alveoli is what we have to check with this test. So there is one the cutoff. If you want to evaluate on the basis of ABG, should we go for a pulmonary resection or not? They have given one PO. If the PO2 is less than 60 or the PCO2 is more than 45, you should go for pulmonary resection. But this is not commonly used, as we have better methods to evaluate the pulmonary functions. The most useful test of the gas exchange capacity of the lung is DLCO. What is DLCO? DLCO is a diffusing capacity of carbon monoxide. It correlates with the total functioning surface area of alveolar capillary interface. So just like we see in predict post-operative FEV1, this is predict post-operative DLCO. So the DLCO less than 40% correlates with both increased respiratory and cardiac complications and is to a large degree independent of FEV1. The DLCO is negatively affected by pre-op chemotherapy and may be most important predictor of complications in this subgroup of patients, because it is FEV1 is unaffected. So DLCO is the one if the patient is received pre-operative chemotherapy. So DLCO will be a very good parameter. So there is one trial, a national emphysema treatment trial, in which it has shown that patients with pre-op FEV1 or DLCO less than 20 had an unacceptably high perioperative mortality rate. So coming to the lung segments, the total subsegments are 42. So on the right, upper lobe 6, then 4, then 12. As right has 3 lobes, left has 2 lobes. Left is 10. So suppose if we are going for right lower lobectomy, so just look at this diagram. So right lower lobectomy. So right lower lobe has 12 lobes. So we'll be removing those 12 lobes. So initially we have to calculate the predictive post-operative FEV1. So initially we have to know the how much FEV1 decrease will be there, because we will be removing the 12 segments from the right side. So 12 divided by number of segments into 100 comes about 29%. The number of subsegments of each lobe are used to calculate the predictive postoperative pulmonary function. So after a right lower lobectomy, a patient with pre-op FEV1 or DLCO 70% of normal, which we can get from the spirometry, would be expected to have a predictive postoperative FEV1 of like 70 into 1 minus number of segments we removing the percentage upon 100, it comes up to be 50%. So if we take this, it's a good patient. There is a low risk of post-operative complications. You can go ahead with the surgery. The third most important respiratory parameter we will discuss, we have to examine, is cardiopulmonary interactions, which is the final and the most important assessment of respiratory function and is assessment of the cardiopulmonary interaction. It's evaluation of the patient's exercise capacity. So exercise capacity is commonly described in units of metabolic described in units of metabolic equivalents of tasks, which is METs, which you must be using already in your PACs. So for an example, sitting quietly, the requirement of the oxygen consumption is 3.5 ml per kg per minute, which is the minimum requirement. And if you're climbing one flight of stair, it is 4 minutes. So there is no absolute definition for the flight of stairs. So, but they say that one flight is around 10 feet and is commonly used standard. So the flight of stairs refers to a continuous series of steps that connects two levels of buildings without any landing or breaks in the steps. It essentially is a set of stairs with one floor and the next. The term can also be used to describe section of stairs between two landings. Suppose there is one stair, again and continuous, there will be another stairs. Patient who cannot give reliable history or are limited in their ability to climb stairs because of comorbidities, we will require simple or formal exercise testing. So the most valid simple exercise test is the maximal distance that a person can walk in 6 minutes, which you all must be aware of. 6 minute walk test, 6 minutes walk test. It shows an excellent correlation with maximal oxygen consumption, which is VO2 max, and requires no lab equipment. So in COPD patients, VO2 max can be estimated from 6 minute walk test distance in meters divided by 30. So if the patient travels around 450 meters, the VO2 max will be 450 by 30, is 15 ml per kg per minute. So what are the other tests for exercise testing? It is shuttle walking, in which a patient walks at a fixed and gradually increasing rate between the two markers, rate of speed, like the speed of walking between the two markers 10 meters apart. So the two pointers are placed like around 2 meters, around 10 meters apart, and person walks from one point to other, and while coming back he has to increase the speed gradually. So the total number of distance which he will cover, that we have to note down. And the distance of less than 250 meters correlates with VO2 max of 10 ml per kg per minute. There is another test, exercise oximetry, which is the easiest one. Patient with decrease of blood oxygen, when there is decrease of blood oxygen saturation, that is SpO2, more than 4% during exercise, are at increased risk. So the formal lab exercise testing is the gold standard for assessment of cardiopulmonary function, and the VO2 max is the most useful predictor of post-thoracotomy outcome. The risk of morbidity and mortality is high if pre-op VO2 max is less than 15 ml per kg per minute, and very high if it is less than 10 ml per kg per minute, that is 35% predicted. Few patients with VO2 max more than 20 ml have it means that more than 20 ml if the VO2 max, these people have a very few respiratory complications. For comparison, just a trivia, VO2 max of Lance Armstrong, which is very famous cyclist, his VO2 max was 85 ml per kg per minute in 2005. Since then, several elite rowers and cross-country skiers have exceeded this limit. Then after pulmonary resection, right ventricular dysfunction appears to be proportion to the amount of functioning pulmonary vascular bed removed. The amount of pulmonary vascular bed will remove proportionately the right ventricular function you will expect. The exact etiology and duration of this dysfunction remains unknown. Clinical evidence of this hemodynamic problem is minimal when the patient is rest. The patient is at rest. But when it's very dramatic, when patient tries to exercise or do some work, the elevation in the pulmonary vascular pressures, limitation of cardiac output, and absence of the normal decrease in PVR is noted. Normally when we exert, there is increase in PVR, there is decrease in PVR, but here there is PVR will increase. So ventilation perfusion scintigraphy is another test which we can do for prediction of post-resection pulmonary function. So what we do is, assessment of the pre-op contribution of the lung or lobe to be resected using ventilation perfusion, lung scanning can be done. So suppose we are removing right lower lobe, the right lower lobectomy. So we'll do this ventilation perfusion scintigraphy in that lobe, and we'll see how actually how much amount of lung parenchyma is actually contributing to the ventilation and perfusion. So if the lung region is resected, is non-functioning or minimally functioning, the prediction of post-op function can be modified accordingly. This is particularly useful in pneumonectomy patients, and VQ scanning should be considered for any pneumonectomy patient who has a pre-op FEV1 and DLCO less than 80. However, VQ scanning is of limited usefulness to predict post-lobectomy function. So normally we use the combination of tests. No single test of respiratory function has shown adequate validity as a sole pre-op assessment. So prior to surgery, an estimate of respiratory function in all three areas, that is lung mechanics, parenchymal function and cardiopulmonary interaction should be made for each patient. These three aspects of pulmonary function form the three-legged stool that is the foundation of pre-thoracotomy respiratory assessment. This is just a brief summary of what we have studied during last 10-15 minutes. There's a box says that a three-legged stool of pre-thoracotomy respiratory assessment. This is very important thing. They'll ask you directly from this table in the Viva, as well as you have to draw this in your exams. So first is respiratory mechanical function, which is the most valid test is predictive post-operative FEV1. The threshold for increased risk is less than 30 to 40%. Same is with the lung parenchymal function test. This is PPO DLCO, which is the threshold is increased risk is less than 30 to 40%. Same for both respiratory mechanics as well as lung parenchymal function. The third test is cardiopulmonary interaction. Most valid test is maximal oxygen consumption, that is VO2 max. So VO2, this is VO2 max. So what is the threshold? Less than 15 ml per kg per minute. With the VO2 max, there is increased risk. The following is the flow diagram for preoperative respiratory investigation of patient for pulmonary research. How should we decide which patient should be chosen for the surgery and which not, which should be spared? So if the functional capacity, the mates of the patient is more than 2, we will go for spirometry. We will evaluate the predictive post-operative FEV1 and predictive post-operative DLCO. If both are more than 60, that means obviously there is less risk, so we can proceed with the scheduled pulmonary resection. And if suppose it is like between 60 and it's decreasing to 30%, so we have to do the simple exercise testing, the 6-minute walk test which we discussed. If it is more than 400 meters, patient is able to walk in the 6-minute walk test, you should proceed for the surgery. If it is less than 400 meters, then you have to go for the cardiopulmonary exercise testing. Okay, so again, the cardiopulmonary exercise testing is common with if the patient has even further deteriorated PPO, FEV1 or DLCO less than 30%. Again, then also you have to go for cardiopulmonary exercise testing. That means if the predictive post-operative FEV1 and DLCO, if it is less than 30, and if even though it is 60 to 30, but 6-minute walk test is less than 400, you have to go for cardiopulmonary exercise testing. And then if in that the VO2 max is more than 10, you should take the patient for pulmonary resection under increased risk for sure. And if it is VO2 max is less than 10, then you have to defer the surgery for medical consultation optimization, and then you can take the patient for high risk consideration. You should after that we should consider high risk and consider for alternate therapies. So in recent times, increased use in minimally invasive surgical techniques has started and has a major impact on assessment of operability in lung cancer patients. Patients previously considered high risk for thoracotomy may not be high risk if the procedure can be done with VATS robotic surgery. The threshold for increased risk in the predictive post-operative FEV1 lobectomy appears to have shifted from less than 40 for open thoracotomy to 30% in VATS. I'll explain that in the upcoming bar graph. You will see the same shift may be also occurred for predictive post-operative DLC. So here you can, as you can see, the predictive this blue one is the for the robotic so blue one is the open group and red are the thoracotomy. So as you can see, the open thoracotomy cases risk has immediately increased when the predictive post-operative FEV1 falls below 30. So the risk is less than 40%. And less than 40% risk is post-op complications are increased magnanimously. But if you say the VATS, if you say here after less than 30, the risk is increased. So that they are telling that from open to the VATS cases, the risk has decreased from 40 to 30%. If a patient has predictive post FEV1 more than 40, the trachea is usually can be. So this all testing also helps us to decide the post-operative management, the plan for extubation, and what. So that's how we're going to discuss now. So if it is predictive post-operative FEV1 is more than 40, the trachea usually can be extubated in the operation room, and the conclusion of the surgery, we can extubate after the surgery is over. We can extubate the patient on the table, assuming the patient is alert, awake, and comfortable. But suppose if predictive post-op FEV1 more than 30 plus exercise tolerance and lung parenchymal function exceed the increased risk threshold, then tracheal extubation can be done in the OR depending on the status of the associated medical conditions. Patients in this subgroup who do not meet the minimal criteria for cardiovascular and parenchymal function should be considered for staged weaning for mechanical ventilation post-op. And if the patient with predicted post-op FEV1 of 20% to 30% and favorable predicted cardiopulmonary respiratory and parenchymal function can be considered for early tracheal extubation if thoracic epidural analgesia is used and if resection is performed with VATS. In increased risk group, the presence of several associated factors and diseases should be documented during the PAC and will enter into the consideration of post-op management. So whatever we do in the PAC, especially this is a very big topic. This is just introductory part. We'll be discussing more into this. So this is all I have. These all notes which I took are from Miller's Anesthesia 9th edition. So you can go and refer to that, and just comment below how you like the class and lecture. This is just the beginning. I'm trying to I know what you mean. So just suggestions are welcome, and thank you.